and then
That's
let
working.
everybody in.
Good morning, everybody. Thank you so much for being here on this very cold Friday. And we have a very full agenda today, so I want to get started. But let's begin, as we always do, with taking a look at the statistics. And today we're going to take a look at the end of the year, which are concerning, because what you see is that as of today, January 21st, from January 1st till today, so that's 3 weeks, we have experienced across Middlesex County 16 overdose deaths, which is exactly the same number we had on January 21st last year. That's not good news because, as you can see, and I think Nora's going to start the little, yep, there she goes. She's amazing. Start that slideshow that will show you. We go to the first slide. Okay, so you will see that and many of you who've been with us remember that beginning in 2017, we started to see a pretty dramatic decline in our number of overdose deaths. And that decline continued in 18, 19, 20. And what we were seeing at the same time, which is the second half of this, is the number of heroin deaths, which in 17 were well over half, had declined to about less than 25% by 2020. We had that big jump up last year, 31 additional deaths. Again, the number of heroin deaths being halved from 50 to 25. But we went from 180 to 211. And I think there's lots of reasons, and we're going to spend some time over the next few months looking at that, probably the number one being the pandemic itself. But I think we really need to think as a group. You know, we drove that number down in 2017 from where it was in the high 200s. And we really cannot allow that to creep back up again. So it's my primary focus right now is going to be thinking of strategies of how we do that. And if you take a look at the map of the county, we do that next one, Nora. Okay, there you go. You will see every one of the marks on this map represents one of the deaths that occurred in 2021. And again, obviously, even one overdose death is too many, but we try to really look at this in terms of clusters and where are we, and we see the same pattern. They are happening everywhere, but concentrated up here in the Lowell area, and then over here in the far right, the sort of city part of, bigger city part of the county, the Arlingtons, Cambridge, Malden, Medford. And those colors of the dots, as you can see from the legend there on the left, tell you what it was that was the drug. If to the extent the medical examiner identified it, we were able to indicate what was the primary drug that was found in somebody's system. And this next chart just really shows you what we saw in words on the initial slides about it in terms of where heroin has been. Oh, I guess we have this slide. This is just sort of a reminder of where different cities and towns have come in. If you look at the different colors, this looks like a great paint wheel, but if you look at the different colors and then match up to the legend on the right, you can see, and if you look at Lowell, unfortunately still occupying a big spot there, but really of the 54 cities and towns, everybody is getting a little bit of a share there. So that is concerning. And then seeing here in 2017, the darker blue, the part that heroin played up to 2021, when heroin is really just a tiny fraction of what we're seeing, and speaks to primarily the introduction of fentanyl. Again, we are tracking where deaths occur, and we continue to see that same trend that began a while ago. You know, when we started this work back in 2013, the vast majority of our deaths were occurring in either outside settings or in sort of public kind of places, fast food, restrooms, and that sort of thing. We've had a complete turnover in that. The vast majority of deaths that we're seeing now are occurring at home or the hotel, and the hotel is a little bit deceptive in the sense that it is not sort of somebody there very quickly. It is usually people in sort of these extended stay type places, or people who've rented a room for 2 weeks or something. So hotel and home are almost interchangeable there. In terms of what that means. And it speaks to what we talked about before, which is the increased usage on the part of people who are dying from an overdose, the social stigma piece of just getting the drugs and retreating to a bedroom or a hotel room or something where people are using. I think it also speaks to the increased training of the public in terms of, I think people are in fast food places and shopping malls or whatever, much more attuned to keeping track of who's in the bathroom, where people are, that sort of thing. So we have managed to avoid as many. We still have a fair number of overdoses there, but we are avoiding overdose deaths in those kind of places. But it is very interesting. You know, 7 years, give or take, is not that long a time statistically to have seen that completely turn around. With respect to the substance that's related to the deaths, that next, there you go. And that just really plays out what you saw on the map. The largest shares being the cocaine, which is a real change. Again, we hadn't seen cocaine for a long time, and we are primarily seeing it now as a vehicle for something else, usually fentanyl. And then the turquoise color, which is, if the medical examiner was able to say it was an opiate, but not able to identify what opiate that is. And then that number, oh, sorry, was it that number of polysubstance being what we find increasing. This, and you see that pink block, again, speaking to people with a very long-term addiction, using more and more to try to satisfy those cravings. Looking month to month, unfortunately, you can see over last year, for the large part, with the possible exception, and then looking year to year for those months, we were seeing an uptick pretty much every month. So it wasn't what we had seen before. Often in the years between 17 and 20, as we drove that number down, we would see 3 or 4 months where it would be very low. For some reason, we'd have a big spike in 1 month. That really isn't the case here. We saw last year really a steady drumbeat of overdoses. And then that comparison year to year kind of shows you the same thing. The factors that we saw in a number of cases, and I've mentioned a few of them, really are the decades-long use of substances. People who, what is concerning is people who've had long-term periods of sobriety, some indicia of suicidality, the polysubstance use, which I mentioned, as well as the social isolation. And that is very different from where we were back in 13 and 14. So that's a real attempt to just give you a sense of where we are. As I said, I'm concerned that we are right now where we were exactly 365 days ago. And our focus really has to be on how do we make the next 11 months be different so we don't end up again showing that increase. So that's just kind of a preview of where we'll be going, what we'll be looking at over the next few months. But turning to today, the real theme for today, and I know we've been looking forward to this and talked a lot about this, was the focus would be on those who are working, supporting pregnant or parenting people who are dealing at the same time often with recovery, maybe neonatal abstinence syndrome. We've talked about this a lot, especially when we've had the folks from Jewish Children and Family Services who run really a great program, the NEST program, which is Newborns Exposed to Substances. It's a support and therapy program. And I'm really happy that they're here today, and we'll be back talking to us a little bit later how COVID and the really exploding mental health crisis has impacted their work. And then finally, we'll hear from Dr. Ruth Paris, who's a research scientist and an associate professor at BU, who's working on an evaluation of exactly those kinds of programs, the programs that are supporting people who are either pregnant or parenting. Our first presenters today, and as everybody knows, I'm always happy when people are nice enough to come back with us, are from the city of Lowell. Catherine Mahoney is at Lowell General, and we've seen Kathy lots of times. And Cheryl Flanders works for the Lowell Community Health Center. They collaborate with support of moms with substance use disorder, opioid use addiction. And Kathy, as many of you remember, has been at Lowell General since 2017, initially as the nurse care manager with the Moms Do Care grant, and then since 2019 as the Women's Health Navigator, where one of her areas of focus continues to be that passion for women and families affected by perinatal substance use disorder. And Cheryl has worked since 19 at the Lowell Community Health Center. She began there as a recovery coach, coordinator for the Supporting Moms Strengthening Families programs. And in 2019, happily, Kathy and Cheryl met each other when the health center developed, as a result of a grant, the program for prenatal and postpartum women with substance use disorder. They've been collaborating since then to make the care of those women and their babies as seamless and supportive as possible. And I want to give a shout out to Cheryl, who has now transitioned into a new role as the licensed addiction drug counselor, but is going to stay as the coordinator of this program. So thank you both for being here, and I turn it over to both of you.
Okay, there you go.
Good morning, everyone, and thank you for, again, DA Ryan and Nora for the invite back to speak with everyone. And so we did want to speak a little bit about our programs and some of the updates that we have since it's been, I think, a couple of years since I spoke. And now with the addition of Cheryl, kind of my virtual colleague. So I'll get started. I know everyone is pretty familiar with the hospital, but I'll tell you just a little bit, kind of a recap of things that are going on in our maternal child health division. So Lowell General has also always had a strong interest in serving this vulnerable population, multidisciplinary team we have, starting with our chief inpatient pediatric hospitalist, Dr. Jennifer Merzicki, our nursing leaders on labor and delivery, the mother infant unit and the pediatric unit, our lead social worker, Kristen Reynolds, and our lactation specialists. In 2015, we achieved the Vermont Oxford Network Center of Excellence in the care of babies with neonatal abstinence syndrome. And then, as the DA mentioned, we had the Moms Do Care grant, our wraparound services between 2016 and 2019. And since then, we've had sort of this ongoing collaboration between the health center and the hospital, which has been very effective. So just a few definitions and numbers. So the hospital in general has an average births of about a little over 2,000 per year. And of that number, generally we have between 40 and 50 opioid exposed infants. And just a couple of quick definitions. The opioid exposed newborn or infant is kind of a general term for babies who are exposed in utero to opioids, either prescribed or illicit. NAS is the group of symptoms that we observe in infants experiencing withdrawal either from opioids or can be other medications. Sometimes we'll see it with gabapentin. And these include problems with eating or sleeping, kind of tight muscles, jittery, some feeding issues, things like that, difficulty consoling. And then a term that you are hearing more often now is NOWS, or the neonatal opioid withdrawal syndrome, which is basically just looking at specifically at babies that are withdrawing from opioids. The maternal risks of opioid use disorder are preterm birth, that being before 37 weeks, stillbirth, and or maternal mortality. And that's something, the maternal mortality is something that we're really taking a look at in the perinatal quality improvement world, because the women with substance use disorder really do take up a large number of women who sadly will die either during the perinatal period or within the year after giving birth. But one of the things that we've developed in the past couple of years in response to the opioid crisis is an MAT program, an inpatient initiation of buprenorphine in the pregnant patient. So in 2019, we developed a protocol based on similar programs at Boston Medical Center and other local centers. It's been sort of we've had a small number of patients, probably just a couple per year between 2019 and 2020. We are finding that community MAT providers, are feeling more comfortable starting pregnant women on MAT. But for those who, want to have more monitoring or who are later in pregnancy, we do have this program for them. The infants are monitored, so it's very safe. Its average length of stay is 1 to 2 nights. And we do have 24/7 availability to do this. It's a no judgment zone. Ideally, if a woman is sort of thinking about this and can come in beforehand for a planning meeting, we try to do that. But obviously we understand that these decisions can come sort of spontaneously. And so we are available 24 hours to start this protocol going. Last year in 2021, we updated our protocol a little bit to allow for increased dosing, increased frequency of dosing during the initiation of buprenorphine, and more emphasis on using comfort meds for women, especially when they first come in, in withdrawal. So we've had a couple of women go through that since then, and that seems to be, definitely more more successful and more comfortable for them. So again, we have a multidisciplinary team. So that includes the consult with social work, and our addictions consult team meets with these women, and we do set up aftercare with a prescriber and give them prescription, a bridge prescription until they are able to get to see someone. One of the other things, and I think I've talked about this before, is our prenatal pediatric consults. They continue to be very popular. Maybe referred either by an OB provider, a recovery coach such as Cheryl, or sometimes even labor and delivery nurses will pick up a need for that during prenatal testing. We review the management of NAS. The consults are multidisciplinary and led by, again, Dr. Merzicki, our nursing staff, and social work. We generally try to complete them in the last month of pregnancy. And we really see that these significantly reduce maternal anxiety. And dads or other supports are welcome, kind of depending on what our current visitor restrictions are, but we really do try to make it, if somebody wants someone else to come in, that we try to accommodate that. Just a little bit about, and again, sort of all of these things I'm kind of going through quickly. We could certainly talk about them at greater length, but during the delivery admission, we do use the Eat, Sleep, Console protocol for our opioid exposed infants, where we look more at, are they able to have like normal infant behaviors? Like, are they able to eat enough to maintain their weight and not lose a lot of weight? Are they able to sleep after they feed? Are they able to be consoled by their caretakers? So can they put them down in order to go take a shower or anything like that? We, again, there is a social work consult during these admissions, and we support them through the DCF process. And at the by the end of the delivery admission, we review with the mom referrals for early intervention, visiting nurse, any behavioral health or substance use treatment needs. And there's the opportunity for welcome family visit, which is a one-time nursing visit. These are just a couple of quick snapshots of, this is data that we submit to the Perinatal Quality Improvement Network, the PINQUIN network, which is a state-run collaborative. The top one, if I don't know if you can see it too well, but basically it's looking at the percent of mothers of opioid exposed infants who have delivered at the hospital and who are on MAT. And it's been running somewhere in the range of like 80 to 90%, which is, you know, which is favorable. There is kind of a caveat in that some of them, perhaps 35 to 40% of them, are also using illicit opioids while on MAT. So obviously that's a number that we really want to see go down. And it actually was lower, but in the last couple of years has been creeping up as we've seen other data creeping up related to opioid addiction, sadly. The bottom graph is the average length of stay among these babies. And these are babies that are born at least at 37 weeks. They're not including our premature babies, but it shows a really nice decrease in the average length of stay. So that initially in 2017, our length of stay was between 2 to 3 weeks, and now it's down to 6 to 10 days. So a couple of ways in which we do collaborate, and these are ways that Cheryl and I are frequently in contact. So we host the quarterly Lowell Perinatal SUD Collaborative, which is kind of developed over the years and includes now people from early intervention, DCF, the community health center, local MAT providers, our nursing and social work department, residential treatment providers, the Bridge Clinic, et cetera. Anybody who's really interested in this population, and we meet quarterly to just kind of discuss trends, any issues with, you know, our working with each other and things like that. So that's been something that people have found very beneficial in just, you know, sharing support with each other. And then most recently we've been working on, the hospital has been a site for the SMART study, which I shouldn't say the hospital, it's really one of the OB practices, our largest OB practice, Circle Health. OB is part of a multi-site research study that originates out of Yale, which is comparing 2 models of care for pregnant women with opioid use disorder, a care coordination model and an echo model. So we are in the care coordination model track. And so we're just looking at what is it helpful to have a care coordinator in the OB office? So that's been really interesting and exciting. And if anybody out there has a pregnant mom who is looking for an OB, please let me know and I can hook you up with them and maybe they can consider being in the study. And then finally, the liaison with Lowell Community Health Center is longstanding between the hospital and the health center. But in our little world, Cheryl and I have developed kind of a system of regular check-ins, just again, looking at trends, you know, sharing kind of updates on numbers. And this is, you know, since the ending of the Moms Do Care program, and then the community health center basically kind of transitioned into their own group, which Cheryl will talk with you about. So I frequently am doing referrals for her group or her, just checking with her around, you know, how do I get supplies for these women that I'm working with in the SMART study. So it's very collaborative. And then she in turn will make referrals to me for the pediatric, the prenatal consults. You know, there are lots of ways that we are just kind of making sure that the transitions for these moms, which can often be so challenging, you know, for someone who's already anxious and sometimes feeling shame about many of them even on MAT, often feel very concerned about the effect of the MAT on their baby. So it's a nice way to kind of provide support along the continuum of care. So I will pass it over to Cheryl to continue to speak about her services.
Kathy, can everybody hear me?
Yep.
Okay, great. Thanks for having me. I was hired in 2019 to help coordinate this program, and it's called the Supporting Moms Strengthening Families Program. And it's a grant, which is a Health Resource and Service Administration. And the program we began, of course, it was before COVID, able to start the program. It's a peer-to-peer led, and it's also led by a Catherine Tager, who is a licensed clinical worker. So at first it was great because the moms could come in to her, and we had a really nice area in the healthcare center where we met, and it was once a week, and they brought their babies, and they, we party there, and we talked about things that were currently on their plate, struggles. They shared resources, and it was just a really good resource for them. All of a sudden COVID hit, and the moms still engage in the group, and what we do is we meeting weekly, so a lot of the moms still engage in that group, a Zoom meeting, so it's really great. Anybody can be referred to the mom, and either a professional from another institution, a family member. Oftentimes we have other moms that refer other moms with substance use. And what they do is they contact myself, and I would just to make sure they're appropriate for the group, meaning that they're not in active addiction, they're motivated towards their recovery, and they want to be involved with the program. They're prenatal and postpartum up to 1 year after delivery. What we're finding is the moms still want to be engaged, and some of the moms are baby, so we keep them in the group and they stay engaged with the program. Contact me. What I do is I enroll them in the program, and I keep and if anybody wants their proof of attendance, things like that, I that with the metrics on a monthly basis. What we do is we meet the client. If they're in active addiction, I can offer them other services, connect other members on my team, whether it's medication-assisted treatment with Suboxone. One of the women I actually met over at Habit Opco in the methadone treatment. So it all depends on where the moms are at. As long as we're engaged, we can enroll them in the program and kind of work with them. The women do not have a patient of the healthcare center. I mean, theoretically, it's great involved, and hopefully they'll engage in more services, but they do not, grant does not state that they have to be a patient of the healthcare center. Goals are to educate and engage the moms and their families about all the services available to them. When we were in person, one of the first moms that I had come in, her grandmother was very concerned about her. So I had her grandmother, and we sat and talked, and I gave her some, educational videos and things. And that really made a difference within her family. It was just really great. What we do is we try to get them involved in the program, and I work under the OBAT team, based addiction team. So what we have available is nurse care management. We have either Suboxone, or we treat other types of disorder. They're able to join in the behavioral health services, whether they want. We have educational support groups, and one of the big, one of the big benefits I found really helped the moms was the prenatal tours in general. And one of the first moms, their family was very concerned The baby's father was very concerned. They just didn't know what was going to happen. Yes. So we coordinated with Kathy, and the whole team met. It helped, alleviate a lot of anxieties with the family and the outcome of the infant as well. We have peer-to-peer recovery, which I think the women really like, because it's not level. We can meet them in the community. It's a very, it's not in, they're not afraid of talking. It's a peer-to-peer. Whether we meet them in the community, we have the Recovery Cafe now. Some of the Phoenix Gym, they meet them in the community, have a cup of coffee. So I think is really important to this, the whole team. And then weekly Zoom meetings, which have been pretty good. I started the metrics and the whole grant here, but when I first started, which was in October of 2000, I had 10 women in the group. And then as you can see, the number of patients, 62. And then the number of people that are actually engaged in 6, and the number of new patients last month was 1. And then we convert person meetings, we went to Zoom, and last month we had 15 women attend the Zoom. So they're still hanging in. It kind of dropped off when we were in person. We had up to women attend, and that's on a monthly basis. So the attendance rate was, and there's still 15 that attend, and that's on a weekly basis. So they're still engaging, and like Kathy had said, some of the women are on their second. They're still engaged in treatment. Next slide. Other resources. Some of the moms, as you know, there's a big stigma to substance use with pregnant women. So what happens is they're afraid to get, because they're afraid of their child being, taken out of their custody. So some get engaged from DCF, because as soon as they deliver the baby and they have a screen for illicit substances, the child, they file a 51A. So oftentimes I will get a referral kind of in that flow, opens up the case. And DCF, I get a lot of referrals from DCF once a lot of the DCF workers know that there's a program now. So I get a lot of calls from DCF. Meet the moms where they're at, and what do they need? They need detox and treatment programs. Do they need safe housing? What we do with DCF is, requiring that they, maybe do a resident program. I work closely with IHR, which is the Institute for Health and Recovery. And then they do an intake with IHR, and what best residential treatment program is good for the moms. And there's not a lot in Massachusetts, especially like the dual diagnosis programs. So what we'll do is we'll appropriately, one of the places where a lot of the women go is the Heart House in Tewksbury. And then we'll help coordinate services to get them in there, and we'll work with them and them engaged in the program. And I do get a lot of the referrals from OB department, because we're in the same building. And when we were in person, a high risk OB meeting, so I would get a lot of the referrals of the moms that were high risk, would engage in services with them to try to meet them where they were at, meet them the appointments, and try to engage them in services. So those are the different ways that the moms get engaged, and we work with them to try to keep them engaged. They want some counseling, maybe they need referrals to another program to talk about. Next slide. Office-based addiction team. Actually, our model is kind of after the BMC model, and it includes MAT with Suboxone, and then we do the Vivitrol injections once a month. Team approach, the primary care doctor is involved, behavioral health providers, can have counselors, recovery coaches, and we do provide just behavioral health services, and we do have medication providers. What we do is a department called PASS, which is the Prevention and Screening Services Program. Anybody can be screened and they can obtain Narcan charge, and we also do Narcan training as well. And in our pharmacy and at Lowell Community, nobody has denial, any kind of health insurance issues. We accept every kind of insurance. If they don't have insurance, they'll work with them to try to get them on Mass Health. So nobody treatment at Lowell Community. TR program is actually under the umbrella of IHR. This is a long time, but it was never in the Lowell area. About 3 to 4 months ago, actually are participating now in the ATR program, and that means access. I'm the liaison that actually puts the referrals into this program. What it enables the client to do, they have to be sober from any illicit substance. And there's real no specific time, but they have to be motivated towards their maintenance. They have to be working with a provider, whether that's, a physician, a recovery coach, but they have to be motivated to stay in recovery. So what I do kind of like a little phone intake with them, and I tell them about the program. Try to do is remove a lot of the obstacles. So once they go through treatment, and they, whether they're on MAT or they're not on any MAT at all, there's a lot of their whole life, needs to kind of be put back together, all the little pieces of the pie, their housing, whether they need IDs, they have no transportation, they need training, all that. So what they do is I put in a referral to ATR, then ATR calls the client. They used to do it in person, but now it's all done by phone. So they'll do an intake to see if the client is appropriate for them. As soon as they do the intake for ATR and they get approved, them on a shopping spree, and they give them $500 to go shopping for and to help them get essentials, self-care and things like that. Aspects of the program that they can use, whether they have a hard time getting, a birth certificate, a driver's license, or just a regular ID, because you go to get a driver's license, you need a birth certificate. Well, if you don't have a birth certificate, you can't get an. All these obstacles for, to stay in recovery are such that, they're having a hard time. So they help them with bus passes, ID, give them the shopping spree. And then there's other parts of it. They actually pay 5 months for sober housing. And then they help them with benefits if they are on disability. They help them with the SNAP card benefits. And then free bus pass. And after that, when they stay in the program, it's a 6-month program. They have a job readiness program. And if they're looking, whether it's to complete their GED, whether they want to go to do vocational training, back to school, or they just want to know the job market and see what's out there, job readiness program that they enroll them in. It's a 3-week program. They lend them a letter, and it's a 3-week program, and they work with Mass Hire and the mission, and they create resumes, they do cover letters, they actually give them their ID so they can do job searches on there, and then they give them top, and if they complete that program, they give them a $600 check. So is really great. And so far, I've enrolled over 40 people about 3 months in this program, and they love it. People are getting jobs, they're getting a bus pass. One of my clients is actually getting his driver first time. So it's a really great program. And the only thing they need to do is to be in sobriety. That's the only requirement. So it's and if anybody, you don't have to be a client of Lowell Community Health Center, refer a client to this program. And when Kathy and I go NATO collaborative meeting, clean slate, actually, a lot of people don't know about this, so able to coordinate with some of their clients as well to get them. So anybody can refer to this program. Does anybody? Okay, next slide. I don't know if you want to join in, our two clients here.
We probably should do them quickly, Cheryl. So yeah, why don't I'll do Tracy and you can do Maria. So Tracy delivered her first child at Lowell General and subsequently disclosed to us that she had been actively using opioids during pregnancy. And so she was initiated on the MAT protocol, and then we made the referral to Cheryl at SMSF. And then we've been able to subsequently collaborate again on her second pregnancy and even share, like, she was moving out of state. And so we were able to identify out of state resources for her.
Yeah, one of the moms actually did really well, and she's actually maintained recovery for over 2 years now. You know, her family and herself and her child, they're doing, but just the proof that these programs work, stay engaged, and I'm hopeful that the grant continues. Thank you.
Thank you.
Thank you so much. I was saying to Kathy that in the chat that I was just kind of gobsmacked to hear about the connections with all of these other programs we've learned about, whether it's Recovery Cafe or Phoenix, or it's just been it's a wonderful program, and I love the fact that you're really supporting folks throughout the entire process and addressing all of those different aspects of the stigma that's associated with substance use disorder. We did have a question about whether there's a clearinghouse or one-stop shop to learn about programs that are available for pregnant and postpartum women. And I don't know whether maybe that's something that one of our other speakers later on can answer. But Kathy and Cheryl, do you know whether there's kind of a clearinghouse for that?
There is on the IHR website, although I looked for it the other day, it may be currently down, but there has been one on the IHR website, which you could just put in your zip code and then it would come up with all of the things. Cheryl, you've seen that as well?
Yes.
Yeah.
Would you be able to put, one of you just put in the chat, the website, the URL for the IHR website?
Sure, I'll look it up during the next presentation.
That
I'll
would
put
be
it in.
fantastic. Thank you so much. Do we have any other questions for our current presenters? If not, I'm going to move on to our next presenters, who are from JF and CS, Jewish Family and Community Services. We have had an opportunity to hear in the past from some folks who work in their NEST program, and I am absolutely thrilled to introduce Jen Meyerhart and Connie White to give us an update about the program and to tell us kind of what is the same, what has changed, and how the events of the past couple of years have impacted their work. So I'm going to turn it over to them right now. Thank you so much, Connie and Jen.
Hi, thank you. Let me just share my screen. I realized that I had the wrong one queued up, but now I have the right one, hopefully. So thank you for having us today. For some of you, this is probably new material. For others, this is old material, but we just wanted to give you a sense of our program, what we do, what our philosophy is, and sort of what has remained the same and changed due to the COVID epidemic. So I am Jennifer Meyerhart, and I'm delighted to be here with Connie White. I'm the program director. I'm also a clinician. And Connie is one of my fabulous maternal recovery specialists. Our program is called Project Nest and First Steps Together. The reason there are two names is really has to do with Project Nest was started at this point about 9 years ago. And then we were lucky enough 4 years ago to receive funding through the Department of Public Health for First Steps Together. So we use the terms interchangeably because we essentially provide the same support for pregnant and new mothers who are in recovery and whose babies were born substance exposed. So who are we briefly? We are housed at the Center for Early Relationship Support at Jewish Family and Children's Service, which is a nonprofit organization based in Waltham. The Center for Early Relationship Support has a whole array of programs supporting new families. So we are there. We serve the greater Boston area, which for us is a pretty large catchment area. We go from Boston all the way up almost to Lowell. We serve some of the South area. So we have a pretty good catchment area. The First Steps Together program have 7 sites that cover a lot of different areas of the state. There are areas, unfortunately, that are still not covered by either us or First Steps Together, but we do fortunately get to at least cover a pretty good swath of Massachusetts. We are a home and community-based service. We see families from, it says consultation, that's usually prenatally all the way up to when the baby turns 3 years old. We see any parent or caregiver who is in recovery or working towards recovery. We're not fee-based, so income has nothing to do with whether or not someone can take advantage of our services. As long as they're in our catchment area, we're available to help support them during these very vulnerable first years with their newborn. We do a combination of infant mental health intervention. Those are our clinicians and peer mentor support, and you'll hear more about that. I just wanted to share some of our core beliefs. This is our context in which we serve. We believe, as Winnicott stated all the way back in 1940, there is no such thing as a baby. A baby does not exist alone. That speaks to our dyadic approach, dyadic meaning we think of the baby and caregiver together when we do our interventions. We believe that addiction is a chronic disease which affects brain functioning. We believe that addiction is often and can be successfully managed with treatment. And our words do matter. Our words meaning what we say to our clients. We are very much, as was said before, a no judgment zone. We're strength-based, and we meet our families where they are, where they start. Some of the things we know from our work is that pregnancy can be a great motivator. Many of our moms come in, some who have lost several children to foster care and adoption, ready and wanting this pregnancy to be different, wanting to take the best care they can of this baby. Some come in with their first pregnancy, and this is what has really made them motivated and determined to work on their sobriety. We know that there are many obstacles. Most of our mothers face a lot of uncertainty, and they don't know what to do or where to get help. They come in sort of in this territory with so many worries and usually say, oh, I'm so glad we found you. We didn't know where to turn. Many of our families have had really mixed experience with providers. Some have felt very stigmatized, shamed, and we work really hard to change that narrative and to help them interface with all types of providers in a positive and helpful way. And we have found that the pervasive feelings that our moms experience, which lead to secrecy, denial, and avoidance, is shame, guilt, and fear. Seems to be very universal with our families. What we do is a dual provider model. We have maternal recovery specialists and we have clinicians. Our clients can choose whether they'd like both a clinician and a maternal recovery specialist or one or the other. Sometimes our families come in and they already have peer support from another program, and they just need a clinician. Sometimes they have a clinician working with them on the dual role of being a mother and being in recovery, and they just want a maternal recovery specialist. Our services are very flexible. Sometimes a family starts with one and adds another. And we collaborate with outside providers and resources within JFCS in order to meet as many needs of our families as possible. Connie is going to let us know a little bit about specifically what our maternal recovery specialists do with our clients, what kind of work they do. So Connie, I'm going to turn it over to you.
Thanks, Jen. Good morning, everyone. So I am one of 4 maternal recovery specialists who work with Project Nest and First Steps together. All of us are in recovery and all of us are moms. We feel that it's beneficial and powerful when one person with a substance use disorder can share their experience, strength, and hope with another. So when we tell a mom, we understand that parenting is hard, recovery is hard, and parenting in recovery is hard. We do know that firsthand. By sharing our own experiences of where we were in our active substance use and where we are today in recovery, we hope to send the message to our moms that you can do it too, and you don't have to do it alone. We help clients to develop and focus on their strengths and capabilities, always encouraging and supporting them with navigating the challenges of parenting while staying sober. In the work that we do differ from a sponsor. We help a mom find her own recovery pathway, one that will work best for her, while a sponsor might work within beliefs and practices of a specific fellowship. In some organizations, a counselor might be discouraged from any self-disclosure, whereas we are encouraged, strongly encouraged, to share our experiences with the moms that we work with. Next slide, Jen. So the opposite of addiction is connection. And because of my own substance use history, I am able to connect with a mom. When I say to her, I understand the struggles you're having, I've been there, I have. Recovery is about attraction and not promotion. We do not tell our moms what to do. We support and encourage them in finding the way that's going to work best for them. We walk beside our clients and provide them with the information that's going to work best for them. For example, there are multiple pathways to recovery. We encourage them to use the recovery supports that they develop that can help them to learn the skills and develop the tools that they need to stay sober and live a healthy lifestyle. We help our clients to develop a family treatment plan that addresses her basic needs and one that will best suit and support her and her family. We might encourage a client to become a part of a particular group that we offer, such as Circle of Security or the Parenting Journey in Recovery. These groups can provide support and encouragement in her relationship with her baby and being a mom in recovery. At Jewish Family and Children's Services, we're very lucky. There are many, many resources available to our client. And an MRS will provide information, will connect them with resources, will assist them with all of these concrete services. We also have a family resource coordinator who can provide application assistance, public benefits information, housing search assistance, and so much more. The coordinator will either work directly with a client or consult with the MRS. We will always outsource if a client needs help with something that we do not provide. Thank you.
Thank you, Connie. That was a great explanation of your role. I'm going to talk a little bit about the role of our clinicians. Our clinicians specifically work to address the impact of substance use and trauma on the parent's mental health, the early parent-child relationship, and infant development. We really focus on being a parent and what gets in the way based on past trauma, ongoing or past mental health struggles, and substance use. We utilize a dyadic infant parent mental health lens. Again, as I said, we believe a baby doesn't exist in isolation, and neither does a mother. We employ and are trained and certified in a range of interventions, among them parent-infant mental health, child-parent psychotherapy, mothering from the inside out, circle of security, facilitated attuned interactions. And we use pieces of those and those intentionally with all of our work. COVID, as we know, has been going on much longer than any of us imagined. We were able, for many reasons, to really hit the ground running when COVID hit. There were so many things that changed for our families. They became incredibly isolated, and we know and believe, as the DA spoke about earlier, that the rise in overdoses definitely has something to do with the incredible isolation. Many of them were suddenly home all day with older children. They weren't able to go out. Most of their groups, support groups, went online. So what we tried to do is address what we knew were going to be some of these really difficult circumstances for our families. We moved immediately to telehealth services. We assessed what their concrete needs were, what was difficult. Some of our parents couldn't get masks. We had tons of volunteers sewing masks. Remember those days when everyone was sewing them? And we would drop them, do what we call porch drop-offs. We had emergency funds and put together packages with diapers, wipes, and other things that families needed to address the urgent concerns. We started a drop-in online group so parents in recovery, our clients, could find a way to connect to other parents. We became creative with our telehealth. We put together packages for all our clinicians and MRSs to utilize during meetings with books and cards and all kinds of things. And we have continued to have ongoing support groups, as Connie mentioned. We just completed another parenting and recovery journey group for our clients. So we've tried to pivot, the fabulous word that we use all the time these days, and really meet our clients' needs so that they felt less isolated, that they were able to continue to meet their concrete needs, and that they could continue to get support. We were researching and sending information immediately about groups that went online, how to access them. And for many of our clients, it became that they couldn't meet us 1 hour or 2 hours a week. They needed to do bits and spurts, 20 minutes here, 20 minutes there, because older kids were home and it was just even more chaotic in their households. So we accommodated what they needed. If they wanted to touch base in that way, we were there. If it was a text, we were there, just trying to help our families know we would meet them where they were at, and we were a continued connection for them. If you have any referrals or questions, this is the information. I think we'll probably be sharing this slide deck, so you don't have to worry about this information, but just so you know, we have a dedicated referral line. I'm always happy to talk, to answer questions. So we're available just if there's anything we haven't covered. I know this was a brief presentation, just wanted to give you an overview of what we do. And I'm wondering if there's time, if there's any questions or anything I can clarify or respond to.
Thank you both. And just another indication of why we are so happy to be working with NEST and all of the programs that Jewish Children and Families has developed. I mean, being the operative word here. So anybody have any questions? Raise your physical hand, put it in the chat, whatever. Yeah, Ruth, Dr. Paris, do you have a question?
Hi,
Hi, Ruth.
hi, Jen. I'm curious how you talked a little bit about how you pivoted with in the pandemic. What's happening now, literally, like right now, in terms of going into homes, not going into homes, doing remote? I imagine you're doing a number of different things. I'm just wanting to know what's happening.
That's a great question, Ruth. And we have pivoted and repivoted and turned. And that's where we're at now. We were starting to, first, when the weather was warmer, we were doing many more in-person visits outside. And then we were slowly starting, if the mom was comfortable and the provider was comfortable, going back in the home. Now we started retreating again due to Omicron. We still, when we can, do outside visits, but it's been just like a lot of moving parts and just trying really to do the best we can as the circumstances just continue to change. Does that answer your question?
Yeah, definitely. It's what I thought, but I just wanted to hear from you. Thanks so much. Yeah, reality.
Anybody else? Questions, thoughts? Lots of people putting in the chat how helpful these presentations have been, echoing what we all see. So thank you. Thank you both.
Thank you.
And turning now again to somebody else who's helped us so often, Dr. Ruth Paris, and I'm happy to see her back here again. Dr. Paris is recognized for her expertise in trauma and infant and early childhood mental health. And she has a particular focus on families that are struggling with substance and opioid use disorders. And with the support of SAMHSA and Federal Health Resources and other federal grants, she's developed and evaluated multiple programs for attachment-based interventions targeted at vulnerable families with young children. And her work is really focused in looking at how best, you know, that sort of mantra of continue to do things that work well and change things that aren't working as well, to have programs that are effective and accessible, feasible in a community setting, are culturally responsive, benefit families raising young kids, and make substantive sense in that field. She's currently evaluating the BRIGHT program, which is building resilience through intervention, growing healthier together, a therapeutic program offered within substance use treatment programs. So Dr. Paris, I'm happy to see you back here and thank you for this.
Thank you so much for your kind introduction, and it's great to be here and great to see some familiar faces. Do I have the ability to share my screen as well?
Yes,
I
you
hope
should be.
so.
You should be all set.
Okay, there we go. Okay, let's see if I can find, sorry, they're not fully coming up. There they are. No, no, no. Oh, these slides are just, they're not cooperating. So I'm going to stop for a second, find them again. Sorry about this. They're not happy in my slides.
They were
Okay.
there. They were
There they are. Okay, they're back. Sorry about that. Let me okay. Okay. Okay, so it's going to be a little bit of a different presentation, but I'm going to try and cut to the chase in terms of this is, I'm going to talk a little bit about a research project and that we have been doing for the past 3.5 years or so. And this is just all the various people who are involved, including Jewish Family and Children's Service. I've worked with them for many, many, many years. And the Health Resources Service Administration that's funding this study. This is a bunch of us who are involved in the, always many, many people involved. I think you probably all know about some of the risks and why we're so involved in trying to make a difference for families, women and infants in particular. We're they're trying to manage recovery and dealing with predominantly for this group that I'm going to talk about today, opioids. One thing that I think Jen made reference to in her presentation, and maybe to break that out a little bit, are some of the brain disruptions that we know that happen with opioid exposure. And so this just gives you a little bit of an idea of how for the moms with long-term opioid use, and this is true for some other substances as well, there's the whole stress and reward system that happens in the brain, which is really important in terms of parenting, gets disrupted. And so it's difficult for the mom often to really access all of her best abilities when having used for a long time. And it also impacts how the child cues the mom. And so that's the focus of the dyadic work that I think Jen and Connie talked about. And it is similarly the focus of our work, because we see the problem in the relationship between the parent and child. So this is a favorite quote about the difficulties that, again, as Jen, thank you, Jen, you sort of did a lot of the work that I was going to start out with, but about babies aren't alone. It's the relationship that we talk about. We do similar relational work. And again, to focus on the fact that the mom is challenged often while managing recovery and trying to maintain sobriety and be able to be attuned to her child. And many of these babies are fussy and come in with some higher risks. And so they're having a more difficult time. So we're thinking about what happens when they come together, and there are more challenges than might be typical in any early parenting relationship. As Jen, I think, implied, is that traditional parenting skills training, we've learned over the years, they don't work so well. So oftentimes our families, and I'm sure many of the families you work with are involved with DCF, and part of service plans tend to be parenting classes. And again, all deference to my colleagues around the state and the country who are doing parenting classes. Some of them are excellent. What we have learned with parents who are in recovery, that some of these classes don't get at what it is that they are truly needing, and that there needs to be some alternative strategies that are more relational approaches and that help in some ways build back the attachment and connection to the child as opposed to the substance. And that takes a different kind of work. So our study is, it's approximately it's a clinical trial. Basically, we call it a pragmatic clinical trial because we're trying to work in the reality of what the sort of the health system offers. And so we have a randomization to 2 interventions. One is BRIGHT, and it was introduced, Building Resilience Through Intervention, Growing Healthier Together. It's a dyadic program. It's much like some of the work that Jen described. And then we offer, the control group is STAR, which is sort of an enhanced treatment as usual. And we're looking to assess the efficacy of improving the parent-child relationship and parenting capacities, and hopefully to decrease child maltreatment. So our aims are much the same. We are not a substance use treatment program. We work in conjunction with substance use treatment. 98% of the women that we've worked with are on medication for addiction treatment, a range of different medications, and also in other kinds of substance use treatment. We support the substance use treatment, but we are not a substance use treatment program. We work with respect. We've had the privilege of recruiting all of our participants in the study from the terrific Respect Clinic at Boston Medical Center, which you probably know is a prenatal clinic for women with substance use disorder that offers a range of services. And Kelly Saya, who's the primary doc there, along with other colleagues, have referred to us and have made us very, very welcome. So BRIGHT has a history. And I just want to give a shout out also to JFNCS and all colleagues there, and to IHR, because we originally developed this intervention together. And we've been evaluating it for more than 12 years in many different substance use treatment programs around the state, including residential treatment, outpatient opioid treatment programs, methadone programs. We've most recently been in the southeast part of the state working with STAR. and now in this randomized controlled trial, the Growing Together study. And just at the bottom of the screen are the many people, and they're not even all of them, who've been involved with this intervention. So we've really learned a lot over the years, and what Growing Together is a chance to test that in what is, kind of my purview, which is doing research and trying to find out really what works about these programs in the ways that we hope they do. Little bit of the background, I'm going to sort of scroll over that. Again, to sort of tease out a little bit about what this intervention does, and I think some of the things that Jen talked about is that the work is both, your last bullet there talks about, the parenting that many of the women talk about that they've experienced has been often very problematic. The women themselves, the moms, are coming in with very extensive trauma histories, often managing post-traumatic stress symptoms. And some of those parenting experiences that they had are internalized, right? How do you learn to be a parent? It's really what you've experienced that you then kind of do with your own children. And some of that gets actually actualized in some harsh and challenged parenting that we've seen over the years. And the kind of interventions that we think are useful address both. They address what are you feeling, what are you thinking, what's happening for you as you're thinking about parenting your child, and what do you actually do? So it is a dyadic intervention. It works, again, prenatally we start, and we work with the mom to anticipate the baby. And then once the baby is there, we work with the mom and the baby to think about their interaction and what's happening for both of them. I'm going to kind of skip over this a little bit. This is our nice little image about the intervention. It sort of encapsulates it pretty quickly. So at the center, of course, is the mother and the baby. And we're interested in the substance use treatment and recovery. We're very interested in her mental health, which is often co-occurring disorders, lots of anxiety and depression and some other issues like post-traumatic stress. We see many challenged parenting capacities, not because the moms don't want to be good parents, but because of the life circumstances. We do see a high risk of child maltreatment, and we know that more than half of the kids involved in our child welfare system have a parent who's, sometimes they say 2/3 have a parent with a substance use disorder. And of course, we're interested in that child's growth and development. What do we do? And I'm going to detail this in a little bit more, but you can see at the bottom there, we're talking about developmental play and developmental guidance and supporting parents being protective of their children, helping the parent attune to their child to think about what does that mean when the child grabs your hand, when the child's crying, their child is, not responding. What are all those actions mean? Lots of emotional support, recovery support, helping the moms with emotion regulation, and also providing concrete assistance, as many of you have talked about today. And we have lofty goals, but we hope to accomplish some, changes in the parent-child relationship for the better, working towards bettering maternal mental health, decreasing trauma symptoms, improving anxiety and depression, thinking about the infant's social emotional development, which is what we assess, and decreasing maltreatment and the risk of it, and hopefully continuing in substance use treatment. This is our what we call a consort diagram. It's a fancy little diagram here that shows, we recruit people, we bring them into both arms of the study. We're not a service program, so we need to have some people go to the experimental, which is our bright intervention, but it's not as if the people in the other group, in fact, many of them have gotten referred to NEST. So all of these women are getting some kinds of services at some point in their journey, because we're lucky enough to live in Massachusetts and where we have many different programs. This is a little bit of a just general idea of who our moms are, and they tend to be women in their early 30s. They are predominantly white. They are predominantly housed, but many living in residential treatment, mostly not married, lots of involvement with child welfare, not their first child, with very low income, many food insecure, have experienced housing instability. So it is a high-risk population, but one with lots and lots of potential. I mentioned, again, high scores around trauma. I point out on the left side, we asked the women different kinds of stressors or traumas that they've experienced in their lives. And you can have 0, or you can have as many as you can list. And in our sample as a whole, people on average talk about 16 different types of trauma, which includes death of someone close, incarceration, substance use of someone close, different kinds of, unfortunately, child and sexual abuse when they themselves were young. And again, it's a lot of trauma that they've experienced. And you can see that the vast majority of them are on, as I said, medication for addiction treatment. This again, just looking at my time here, I'll take just a few more minutes just to detail a little bit more about, this is what I said before, but here is a little bit more of the details of what we think is useful. And again, our goal is improving the parent-child relationship. So we want to, as I said, validation, we want to validate feelings and generally offer recovery support and work in conjunction with substance use treatment. Lots of problem solving and lots of what Jen referred to as infant parent work. What does that really look like? That means the clinician is in there supporting sort of the attachment, keeping the baby in mind, mentioning the baby even when the baby isn't in the session. We use devices like wondering what the baby is thinking and might speak for the baby. It's a lovely thing that you can do, and actually voice what the baby might be experiencing, which I think is a little bit different, but is something that I think people really appreciate. Lots of help with self-regulation and affect regulation, which women, when they're in recovery and trying to work emotions that are very intense around parenting, and babies having intense emotions, having new strategies for ways of reflecting on what they're feeling and helping their baby manage their own emotions. It's a little bit more detail. Our clinicians, like the ones in Jen's program, work very actively with child welfare and might accompany a mom to or remotely, might be a witness to the processes and experiences that that mom is having in trying to parent her young child. We're very curious about the mother's experiences. Many of these women tell us that they've never had anybody ask so much about what their experiences are. This is because we have a very intensive both research protocol, but it also extends into our intervention. And so we want to know what their experience, what do they think, what do they want? And that's new for many of these moms, that they haven't had that experience before. We are, like many of the other interventions, flexible and want to demonstrate availability. And again, I said we offer concrete assistance in the way that we can. Having launched at BMC, people are often very connected with services through BMC, and if not, we connect them right in. There is a follow-up clinic at Boston Medical Center for children who were born substance exposed, and we work closely also with the pediatricians and social workers and patient navigators in that clinic as well. Okay, this is a little bit about what we've done, and I'll end with this, that we enrolled 60 women in our study. The pandemic, I'm not going to go into the details of how it turned everything upside down, but we went remote as well, and we pivoted as well. And Bright has now been in residential treatment in methadone programs and now in a prenatal clinic. We believe that the time to start is in pregnancy, and to go into parenting in the early time period. And we, like the NEST program, think that things should go on for at least a period of time, minimally a year. Our program, partly because we're funded by the feds and you don't get interventions funded to study for that long. We studied our moms in an intervention for about 8 months, and then we have a follow-up. We are listed as emerging practice with the Association for Maternal Child Health Programs. Once our data is analyzed, which is starting to happen right now, we might be able to sort of up that into a more of an evidence-based intervention depending on our results. And we've presented actually all around the world, including in the United States, to all sorts of other places, because I think Massachusetts is lucky in having all the programs that we have, and we're trying to share them both around the country and around the world. And we do what we do in academia, and we write papers, and we hopefully more research proposals. And for me, it is trying to disseminate what we've learned and teach other people how to do this type of intervention to make a difference for mothers and babies. So that's one of our moms. It's her very cute little baby. So, okay.
Thank you, Doctor.
Wow.
Questions, thoughts? That was a lot of great information. Get myself, there we go. There we go. Okay. Questions, comments for any of our panelists? Anything? Trying to keep track here.
I mean, I was
Go ahead,
just wondering, the value of, obviously the value of the research is manyfold, but one of the things is if you can kind of go up in that from an emergent to a evidence-based, does that mean that people get more funding to do the work, or what does that mean for potential providers?
Sure, great question, great question. These days, as you might know, and probably other people here knows, that you know, the feds and other funders want to fund evidence-based practices. They believe that they want to fund something that they know has worked somewhere else. And as innovative as some, you know, of the programs that we have, for better or for worse, this is the era of sort of evidence-based practice. And I think mostly it's for better, even though sometimes it's a little narrow in the way they might define things. There are a number of different clearinghouses where states can go in, community agencies can go in, and they can apply for funding. And they would say, you know, I want to do the BRIGHT intervention because BRIGHT is listed on, you know, Association for Maternal Child Health Programs as a X practice, or it's listed under the California Clearinghouse, or there's a number of others. And there's evidence out there that it's worked in, you know, Massachusetts and in various different places, and the likelihood of them getting funding is going to be greater. That is sort of in short order what happens with evidence-based programs.
Great, thank you.
Anything else?
All right, I'm not seeing hands
yeah.
raised.
Oops, okay, yeah, thank you. Thank you to everyone today. I mean, these were amazing presentations, hopefully gave people a really good sense of where we are today in terms of being able to help folks that you're interacting with who may be pregnant or I just remind people that next month, February 24th, we'll be meeting. Part of that meeting will be John Kelly back with that really granular excuse me, information that he's able to bring us about deaths, and also just ask people to start thinking a little bit really about what we can be doing. You know, as the numbers go up, it requires us to sort of up our efforts. And we can certainly do that. We have done that before. I think if you believe the papers today, we may be getting to a better with Omicron. I also call your attention to the paper today regarding our friends with GOTS and what wastewater testing. Remember, you heard that here first when we had them at one of our Lowell meetings when they were first starting that company. And on the Globe website today, there's a big profile of the women who started the company. So I feel a great kinship with the work they've been doing because of them coming to us when they were just beginning. So does anybody else have anything that you're doing or any programs people are running that they want to give a shout out for? The glue that holds us together. Rita.
Thank you. First off, I want to say about the wastewater treatment plant and how they can detect different things from testing it. I happened to go for my quarterly checkup to the heart doctor, and he was telling me about it. I said, well, let me tell you, I first heard about this from DA Marion Ryan. So that was a beautiful thing. And I also want to thank you for your role in ringing the bell for the Salvation Army. You think you're just the opioid task force queen, but you're not. You're the Salvation Army queen. Thank you so much. Thank you.
Oh, thanks, Rita. Rita and I always manage to be perched outside the Owl Diner on the coldest day of December with our bell. And I spend a lot of time walking into traffic while Rita is charming people on the sidewalk. But it's a lot of money for a good cause.
Yes, it is. Thank you.
Of course. All right. Anybody else? Anything going on? All right. Thank you all. Stay safe, stay warm. Have a good weekend. We'll see you on February 24th. And once again, thank you to all of our speakers. Nora, thank you for making this all work. Take care. Be well.